Ever felt like you need, I don't know, a secret decoder ring just to really wrap your head around a complex medical diagnosis?
Oh, definitely. Especially when it's something really nuanced, hard to pin down, and honestly, sometimes a bit overwhelming.
Exactly. Well, you're definitely in the right place today. We're doing a deep dive into two conditions that are, well, incredibly complex and often misunderstood: endometriosis and adenomyosis.
Yeah, and our mission here is really to cut through some of the noise, pull out the key insights from the medical sources we've looked at, and give you a clear, solid understanding.
Right. Hopefully, you'll walk away with the crucial details, maybe some surprising facts, and a real sense of why these conditions are such a challenge, both for patients and doctors.
And what's really fascinating right from the start is how they're almost studies in paradox. Like, how can they be so widespread but sometimes cause no symptoms at all?
Or how the level of pain someone feels might not line up with how much disease is actually visible. It's complex.
It really is.
Okay, so let's start with endometriosis. Sometimes it gets called the elusive invader, which feels pretty apt. So, at its core, endometriosis is defined by having functioning endometrial tissue. You know, the glands and stroma that normally line the inside of your uterus, but finding it outside that lining.
And it's useful to make a distinction here straight away. If that tissue grows into the muscle wall of the uterus itself, that's technically endometriosis intern, or what we usually call adenomyosis.
Right, which we'll get to later.
Exactly. But if it's anywhere else outside the uterus, that's endometriosis externa, or just endometriosis generally.
And what strikes me is this contrast you mentioned. It's technically benign, so not cancer,
Correct.
but it acts locally invasive, almost like it's aggressively pushing into tissues, and it can spread really widely.
It absolutely can. And then there's that hormone paradox. The body's natural cyclic hormones make it grow, yet continuous hormone treatments are often used to try and suppress it.
It's like fighting fire with a different kind of fire, as you said. Very counterintuitive. And the prevalence, the sheer number of people affected, that seems to be a growing concern. Our sources suggest it's been on the rise over the last few decades.
Yeah, and there seem to be both real and apparent factors driving that increase. The real factors are more societal shifts.
Like people marrying later, maybe delaying having their first child, having smaller families overall.
Precisely, those kinds of changes. And then the apparent factors are more about detection, like the increased use of diagnostic laparoscopy. That's the keyhole surgery to look inside. And just generally gynecologists being more aware of it now. So while it affects maybe around 10% of the general population.
Which is already significant.
Right. But then you look at women struggling with infertility.
Yeah.
And that number jumps dramatically to like 30 or even 40%.
Wow, that's a huge leap, 30 to 40%.
It really is.
Okay, so this is where, for me, it gets really interesting almost. Mind-bending, really. The geography of endometriosis, where it can actually show up.
Right. It's not just confined to the pelvis.
Exactly. While it's common in places, you might sort of expect the ovaries, the pelvic lining, that pouch of Douglas behind the uterosacral ligament.
The usual suspects, so to speak.
Yeah. But the sources point out some really unexpected spots, like abdominal scars, maybe from C-sections?
Yep. C-section scars, the belly button, even episiotomy scars.
Okay, and then it gets even wilder. The truly remote sites.
This is where it gets really surprising. We're talking lungs. The pleura, which lines the lungs, the ureter, the tube from the kidney.
The kidney itself.
Kidney itself, yes. Even arms, legs, and believe it or not, the nasal mucosa, the lining inside your nose.
Inside the nose. How is that even possible? It really makes you wonder, how does this tissue travel so far?
That's the million-dollar question, isn't it? And it leads us right into one of the biggest puzzles, the pathogenesis. How does endometriosis actually start and develop?
And the key thing seems to be that the cause is still, well, pretty unclear. It's full of different theories.
Exactly. And no single theory seems to explain all the cases, which is why it's such a challenge.
So what are the main ideas then? What are these theories?
Well, the most well-known is probably Sampson's theory of retrograde menstruation. The idea is that during a period, some menstrual blood flows backward up through the fallopian tubes.
Instead of just out.
Right. And this backward flow carries endometrial cells that implant in the pelvis. Now, this explains pelvic endometriosis pretty well.
But not the lungs or the nose.
Exactly. It doesn't explain those distant sites. So it suggests maybe other things like genetic or hormonal factors need to be involved too.
Okay.
Then there's coalomic metaplasia. This theory suggests that cells lining the abdominal cavity or other areas can actually transform into endometrial-like cells, maybe due to chronic irritation. This could explain sites like the belly button or organs in the abdomen.
Ah, okay, so transformation rather than travel.
Sort of, yes. Then there's direct implantation that explains finding it in surgical scars, like after a C-section. The tissue gets transferred during the procedure.
Makes sense.
And for those really distant sites, we have the lymphatic theory and the vascular theory. These propose that endometrial cells spread through the lymph system, or the bloodstream, like how cancer can metastasize.
That would explain how it reaches the lungs or limbs, right?
Precisely. And finally, we can't ignore genetic and immunological factors. The sources mentioned a significantly higher risk, like 6 to 7 times higher in first-degree relatives.
So it runs in families.
It often does. And the immune system seems to play a role, too. Things like activated macrophages, these are immune cells, might actually help the endometriosis cells grow by releasing certain chemicals like cytokines and TNF and helping them resist dying off.
Wow. So the immune system might be helping it instead of fighting it?
In some ways, yes. And interestingly, these same macrophages might also reduce sperm motility, which could link back to the infertility issue.
Huh. And you mentioned environmental factors briefly.
Yeah, there's some research looking into things like dioxins, but that link is still being investigated. The main point is, it's likely not just one thing. It's probably a combination of these factors depending on the person and the location of the disease.
So a real puzzle. Now, what about the pathology? What does this misplaced tissue actually look like and do inside the body?
Well, the ectopic tissue, the tissue in the wrong place, it does respond to ovarian hormones, just like the normal uterine lining. But there's a difference. While you consistently see proliferative changes, meaning the cells grow.
Like they do in the first half of the menstrual cycle.
Exactly. But the secretory changes the ones that happen after ovulation to prepare for pregnancy. Those are usually absent or minimal, probably because the tissue doesn't have the right hormone receptors.
Okay. And what happens when this tissue bleeds each month?
That's where you get some characteristic issues. If the bleeding happens within a confined space, like inside an ovary, the old blood collects and forms these cysts called chocolate cysts.
Because of the dark old blood.
Exactly. They're quite common. But even just the irritation from this cyclic bleeding in other areas causes inflammation and a dense tissue reaction. This leads to fibrosis, scarring, and adhesions.
Adhesions. Those are like bands of scar tissue sticking organs together.
That's right. They can cause a lot of pain and problems by distorting anatomy. But here's something surprising the sources mention. Even with really dense adhesions sticking pelvic organs together, often the fallopian tubes themselves remain open or patent.
That is surprising. You'd think they'd get blocked easily.
You would. And visually, when a surgeon looks inside during laparoscopy, they might see those classic powder burns, tiny black or bluish dots, often on the ligaments behind the uterus or in the pouch of Douglas.
But it's not always black dots.
No. You can also see more active-looking lesions, maybe red, flame-shaped areas, or sometimes whitish patches on the peritoneum. It varies.
Okay. So moving on to the clinical features, who typically gets endometriosis and what are the symptoms? You mentioned it's full of contradictions here.
It really is. The sources suggest a common profile is often someone who hasn't had children, or perhaps has few children, typically aged between 30 and 45. There's often a history of infertility or taking longer to conceive, and frequently, that family history we talked about.
But here's the big paradox.
Right. About 25%, a quarter of patients, have no symptoms at all. It's found completely by accident during surgery for something else.
A quarter.
Wow. Yeah. And maybe even more crucially, the severity of symptoms is not related to the extent or amount of disease seen.
So someone could be covered in lesions and feel nothing.
Pretty much. Or someone could have just a few tiny spots and be in absolute agony.
That must make diagnosis and treatment so difficult. You can't just rely on what you see.
Absolutely not. It forces you to listen to the patient's experience above all else. What does seem to correlate more with pain is the depth the lesions penetrate into the tissue. Lesions deeper than about 5 millimeters are more strongly linked to pain symptoms.
Okay, that makes sense. So what's the most common symptom people do experience?
That would be dysmenorrhea, painful periods. It affects about 70% of symptomatic patients. And typically, it's a secondary dysmenorrhea, meaning it started later in life, not with their very first periods.
And it gets worse over time.
Progressively worse, yes. The pain might start a few days before the period, get really bad during, and even hang around for a bit afterward. Patients often describe it as a deep, aching pain, sometimes felt in the lower back or rectum.
And that's caused by inflammation?
Largely, yes. It's thought to be due to increased production of inflammatory chemicals like PGF2-alpha from the endometriosis tissue itself.
Okay. What other symptoms are common?
Well, abnormal menstruation is fairly common, especially menorrhagia that's very heavy, or prolonged bleeding seen at about 20%. Infertility is a big one, affecting a huge proportion, maybe 40 to 60% of patients.
40 to 60%. That's staggering.
It is. Deep dyspareunia, which is pain during or after sexual intercourse, affects maybe 20 to 40%. And then there's just chronic pelvic pain, which might be present outside of periods too.
And that can have multiple causes, right? Like the inflammation, the adhesions.
Exactly. Inflammation, tissue damage from the implants, the adhesions, pulling on things, maybe direct nerve irritation. It's complex.
And can it cause symptoms related to other organs, depending on where it is?
Absolutely. If it's on the bladder, you might get painful urination or blood in the urine. If it's on the bowel, painful bowel movements, or even rectal bleeding during periods. Chronic fatigue is also very commonly reported.
And those really rare cases, like with the lungs.
Yeah, in very rare cases where it affects the lungs, someone might actually cough up blood that's hemoptysis or have chest pain that cycles with their period, called catamenial chest pain.
Incredible. Okay, so with all these varied symptoms or sometimes no symptoms, how do doctors actually diagnose it?
Well, clinically, a doctor might suspect it based on that classic symptom pattern, the worsening period pain, pain with sex, infertility, especially if they find certain things during a pelvic exam, like tenderness or nodules, particularly in that pouch of Douglas area.
But you said the physical exam isn't always reliable.
That's the catch. The sources are clear. Physical exams have poor sensitivity and specificity, meaning they can miss it easily or suggest it when it's not there. Many patients have a completely normal exam.
So exams aren't definitive. What about blood tests? I've heard of CA-125.
Right, CA-125 is a serum marker. It can sometimes be elevated, particularly in more severe endometriosis, and it can be useful for monitoring treatment response or checking for recurrence after surgery. And this is a big but, it's not specific at all for endometriosis. Many other things can raise CA-125 levels.
So not a screening test. What about imaging, ultrasound, MRI?
Imaging has its place. Transvaginal ultrasound, TVS, is pretty good at spotting ovarian endometriomas, those chocolate cysts. MRI is more sensitive, especially for detecting deep infiltrating endometriosis, where it's gone deeper into organs like the bowel or bladder.
But can imaging see everything, like those superficial powder burns?
Generally, no. Imaging alone, even MRI, often cannot reliably diagnose the more superficial peritoneal endometriosis scattered on the pelvic lining.
So if exams, blood tests, and imaging all have limitations, what's the definitive way to diagnose it?
Laparoscopy. That's the surgical procedure we mentioned earlier. It's considered the gold standard.
Why is it the gold standard?
Because it allows the surgeon to directly see the lesions, their location, size, appearance. They can take biopsies to confirm the diagnosis under a microscope. They can accurately stage the disease based on what they see, map out adhesions.
And even treat it at the same time.
Exactly. It offers the opportunity for diagnosis and immediate surgical treatment in one go. That's when they might see those powder burns or other typical appearances directly.
Oh, okay, that makes sense. Now, beyond the symptoms we've discussed, are there other potential complications of endometriosis?
Yes, there can be some serious ones. We touched on endocrinopathy, hormonal imbalances contributing to infertility. Those chocolate cysts can sometimes rupture or get infected, which causes acute, severe pain.
Like an emergency situation.
It can be, yes. And then there are obstructive problems. If endometriosis grows around the bowel or the ureters, it can block them, potentially leading to bowel obstruction or kidney damage if urine can't drain properly.
That sounds serious.
It can be. And although it's very rare, there's a small risk of malignant transformation over time, usually into a specific type of cancer called adenoacanthoma. It's not common, but it's a recognized possibility.
Right. And you mentioned staging during laparoscopy. Tell us a bit about that.
Sure. The most common system is the American Fertility Society, or AFS, scoring system. It assigns points based on the location, size, and depth of implants and adhesions seen during surgery. The total score puts the disease into stages minimal, mild, moderate, or severe.
And what's the purpose of staging?
The idea is to help predict prognosis, guide treatment choices, and evaluate how well treatment works.
But does it have limitations, especially given what you said about symptoms not matching the extent of disease?
Exactly. That's the main issue. The staging system requires surgery. There can be some variation in how different surgeons score things. And Most importantly, it doesn't correlate well with the level of pain someone experiences.
So stage 1 could hurt more than stage 4.
Absolutely. Nor does the stage perfectly predict fertility outcomes or dictate the single best therapy. So it's a useful tool for surgeons, but it doesn't tell the whole story for the patient.
Okay, so it's complex to diagnose, complex to stage. What about treatment? What are the goals?
The main goals are pretty clear: abolish or at least minimize the symptoms, especially pain, improve fertility if that's desired, and prevent the disease from recurring after treatment.
But that sounds challenging given we don't fully know the cause.
It is challenging. And because the origin is obscure, treatment is often focused on managing the disease rather than a definitive cure, unless you go for very extensive surgery.
Are there any preventive measures?
The sources mention a couple of things, though they're not strongly evidenced. Maybe avoiding certain uterine procedures around the time of menstruation, or for someone with a strong family history who wants children, perhaps encouraging earlier conception. But these are more theoretical.
What about just watching and waiting?
That's called expectant management. It's an option for very minimal or mild cases, maybe with just NSAIDs, anti-inflammatories, for pain relief.
And you mentioned pregnancy can sometimes help.
Yes, interestingly, pregnancy often leads to a regression or even cure of endometriosis. The sustained high levels of hormones during pregnancy, particularly progesterone, cause the ectopic endometrial tissue to shrink and often disappear. It's like a natural suppression.
That's fascinating. But what about medical therapies for those not pregnant or trying to conceive?
Medical therapy is a mainstay, but it's crucial to understand it's generally suppressive, not curative. It manages the disease while you're taking the medication, but it doesn't eliminate the underlying tendency for it to grow.
How do these medications work?
They usually work by altering the hormonal environment. Some induce a state of pseudopregnancy, mimicking pregnancy hormonally, usually with combined estrogen-progestogen pills. Others induce a pseudomenopause.
Shutting down periods.
Essentially, yes. Drugs like danazol used to be common for this, or more currently, GnRH agonists, which suppress the ovaries and create a temporary menopausal state, sometimes called medical oophorectomy.
Okay, let's break those down. Combined pills.
The standard birth control pill, often used for milder disease, or if someone wants contraception anyway and needs symptom control. They provide continuous hormonal suppression if taken without a break.
What about progestogens alone?
Progestogens, synthetic progesterone, can be very effective. They come in various forms: pills, injections, or the levonorgestrel-releasing IUS, the hormonal IUD.
The IUD, for endometriosis.
Yes. The LNG IUS is highlighted as being especially useful for rectovaginal endometriosis, that deep kind between the rectum and vagina. It delivers the hormone directly to the pelvic area.
What about danazol? You said it used to be common.
It's used less now. While effective, it has a pretty high recurrence rate after stopping at around 40%, and the side effects can be quite intense and sometimes intolerable for patients. Things like weight gain, acne, voice deepening.
Masculinizing effects.
Yes, androgenic side effects.
Yeah.
And importantly, you absolutely must use barrier contraception because if pregnancy occurred, it could cause virilization development of male characteristics in a female fetus. So big downsides.
Okay. And the GnRH analogs, the ones causing medical menopause.
Right. These are injections or implants.
Mm.
They are very effective at suppressing the disease and relieving pain, but they do induce menopausal symptoms like hot flashes, vaginal dryness, and potential bone density loss if used long-term without add-back therapy.
Add-back?
Yeah, sometimes low doses of estrogen and or progestogen are given alongside the GnRH agonist to counteract those side effects without reactivating the endometriosis too much.
Are they better than danazol?
The side effects are considered more tolerable than danazols, but GnRH analogs are usually the most expensive hormonal option.
So with all these options, is one clearly the best?
That's the tricky part. The sources emphasize that no single medical treatment is definitively superior when you weigh everything: pain relief, impact on future pregnancy rates, recurrence rates after stopping, cost, and side effect profiles. It really depends on the individual patient's situation, priorities, and tolerance.
And recurrence is still a big issue.
Unfortunately, yes. The overall recurrence rate after stopping medical therapy is estimated to be around 40% within 5 years.
Okay, so if medical therapy isn't curative or isn't enough, when does surgery become the main option?
Surgery is usually considered for several reasons. If symptoms are severe and aren't responding well to hormonal treatments, if there's deep infiltrating endometriosis causing significant organ issues, or if there are ovarian endometriomas, those chocolate cysts, especially if they're larger than, say, 1 centimeter or causing pain.
And there are different types of surgery, right? Conservative versus definitive?
Exactly. Conservative surgery aims to remove the endometriosis while preserving the uterus and ovaries, thus preserving reproductive function. This is usually done laparoscopically, keyhole surgery.
How do they remove it?
They can excise it, cut it out, ablate it, destroy it with heat or energy, or use laser vaporization. The goal is to remove as much visible disease as possible.
Does conservative surgery actually help?
Yes, the evidence shows that surgical treatment generally improves both fertility outcomes and symptoms, particularly for women with moderate to severe endometriosis.
What about those ovarian cysts, the endometriomas?
For small ones, sometimes just draining them, aspiration is done, but they often recur. For larger ones, the preferred approach is usually laparoscopic cystectomy, carefully removing the cyst wall while preserving as much healthy ovarian tissue as possible.
Okay. And then the definitive surgery.
Definitive surgery means removing the source of the problem and the target organs. So that's typically a hysterectomy, removing the uterus, along with bilateral salpingo-oophorectomy, removing both fallopian tubes and ovary.
Removing the ovaries, too.
Yes, because the ovaries produce the estrogen that feeds the endometriosis. Removing them ensures the hormonal stimulation stops.
When would someone choose that route? It sounds very final.
It is. It's usually reserved for women with severe advanced disease who have completed their families, have no desire for future fertility, and haven't had success with other treatments, or are experiencing debilitating symptoms.
Got it. Is there ever a role for combining medical and surgical therapy?
Yes, combined therapy is sometimes used. Giving hormones before surgery might help shrink the lesions and reduce their blood supply, potentially making the surgery easier or more complete.
And after surgery?
Hormones after surgery might help destroy any tiny residual implants that were missed and can help control pain long term. However, and this is important, postoperative hormone therapy generally does not seem to improve fertility rates beyond what surgery alone achieves.
Okay, that's a really thorough look at endometriosis. Now, let's shift gears slightly to its sister condition, adenomyosis. You mentioned it's like endometriosis in turn.
That's right. Adenomyosis is specifically when the endometrium, again, both the glands and the stroma, grows directly into the myometrium, the muscular wall of the uterus itself.
So not outside the uterus, but burrowing into its own wall.
Exactly.
What causes that? Is it the same as endometriosis?
The exact cause is also unknown, but it seems related to different factors than external endometriosis. It's often linked to things like having had multiple childbirths or perhaps trauma to the uterine lining, like from a vigorous D&C curettage procedure. Excess estrogen might also play a role.
And can you have both conditions at once?
Yes, quite often. The sources say pelvic endometriosis coexists with adenomyosis in about 40% of cases.
Pathologically, how is it different inside the muscle? You mentioned something about a capsule earlier.
Right. A key difference from something like a uterine fibroid, which is also a growth in the uterine muscle, is that adenomyosis typically does not have a distinct capsule around it. It just diffusely infiltrates the muscle tissue.
So it's harder to just shell out like a fibroid.
Much harder, often impossible. To the naked eye, a uterus with adenomyosis often looks symmetrically enlarged, kind of bulky and boggy. When you cut into it, the muscle wall might look thickened and have this sort of trabeculated or mesh-like pattern. You might see tiny blood spots within the muscle, too.
And microscopically, does it respond to hormones like endometriosis?
Less so, generally, because the endometrial tissue that invades is predominantly from the basal layer of the endometrium, which is less responsive to the monthly hormonal cycle compared to the superficial layers that shed during menstruation. So you don't typically see the same dramatic cyclic changes within the adenomyotic tissue.
Okay. What about symptoms? Who usually gets adenomyosis?
The typical patient profile is a bit different from endometriosis. Adenomyosis patients are usually parous, meaning they've had children in about 90% of cases. And they tend to be older, often over 40 in about 80% of cases.
So often later in reproductive life after having kids.
Generally, yes. And just like endometriosis, a significant portion, maybe around a third, are actually asymptomatic. It might only be discovered when the uterus is removed for other reasons and examined under a microscope.
But for those who do have symptoms,
the two main complaints are menorrhagia, really heavy periods in about 70%.
Why does it cause heavy bleeding?
Probably a combination of factors. The uterine cavity might be enlarged due to the thickened walls, providing a larger surface area to bleed. Also, the infiltrated muscle might not contract effectively to clamp down blood vessels during menstruation.
Okay, heavy bleeding. What else?
The other key symptom is dysmenorrhea, painful periods affecting about 30%. But it's often described as a more colicky, crampy pain thought to be due to abnormal uterine contractions trying to expel blood against that infiltrated, less compliant muscle. And like endometriosis, it tends to be progressive, getting worse over time.
Any other symptoms?
Sometimes infertility can be associated with it, though the link is less clear than with endometriosis. Dyspareunia, painful sex, can occur, and sometimes urinary frequency if the enlarged uterus presses on the bladder.
How is adenomyosis diagnosed then if it's inside the muscle wall?
Imaging is key here. Transvaginal ultrasound, PVS, is often the first step. Experienced sonographers can look for characteristic features like that honeycomb or Swiss cheese appearance within the myometrium. Those are small cystic spaces. They might also see ill-defined borders between the endometrium and myometrium, or increased blood flow within the muscle.
Is ultrasound definitive?
It can be highly suggestive, but MRI is considered more specific and accurate for diagnosing adenomyosis.
What does MRI look for?
MRI focuses on the junctional zone, or JZ. That's the thin inner layer of the myometrium right next to the endometrium. In adenomyosis, this zone becomes thickened. A JZ thickness of 12 millimeters or more on MRI is considered highly indicative of adenomyosis. Well, if it's less than 8 millimeter, it usually rules it out.
Okay, MRI seems pretty specific then. How about treatment for adenomyosis? Is it similar to endometriosis treatment?
There are some overlaps, but also key differences. For symptom control, NSAIDs can help with pain and might reduce bleeding somewhat.
What about hormones? You said they have less effect.
Right. This is a major contrast to external endometriosis. Because the adenomyotic tissue is less hormone responsive, long-term hormonal therapies like GnRH agonists aren't typically used as a primary treatment for the adenomyosis itself, although they might be used short-term for severe symptoms or before surgery.
But what about the hormonal IUD, the LNG-IUS?
Ah, yes. The LNG-IUS can be quite effective for managing the symptoms of adenomyosis, particularly the heavy bleeding menorrhagia and the painful periods, dysmenorrhea, because it delivers progestogen directly to the uterine lining and muscle.
So it helps symptoms but doesn't treat the underlying infiltration.
Exactly. It manages the consequences, often very well, but the adenomyosis is still there.
So what is the definitive treatment if symptoms are bad and things like the IUD don't work or aren't suitable?
For women who have completed their childbearing and are significantly bothered by symptoms, the definitive treatment for adenomyosis is hysterectomy removal of the uterus. Since the disease is within the uterine wall, removing the uterus removes the disease.
Right, that makes sense. A very different approach than often needed for endometriosis scattered outside the uterus.
A very different surgical endpoint, yes.
Okay, we've covered a huge amount of ground here on both endometriosis and adenomyosis. It's really clear how complex and, frankly, challenging these conditions are.
Absolutely. From the diagnostic puzzles to the treatment complexities and the sheer impact on quality of life.
So what does this all mean for you, our listener? When we look at conditions like endometriosis and adenomyosis, with their multiple competing theories of how they even start, the incredibly varied symptoms, sometimes severe, sometimes absent, often not matching the visible disease.
Yeah, and the complex treatment pathways needing really individualized approaches.
It just really underscores how incredibly intricate the human body is, doesn't it?
It really does. And it also highlights why things like continued research, truly patient-centered care that listens beyond just the scans or surgical findings, and persistent advocacy are just so vital.
Especially for people living with chronic conditions like these that just don't fit neatly into a simple box or explanation.
That ongoing pursuit of understanding not just the what is happening, but the why it matters to the individual experiencing it, that feels like the deepest dive of all, really.
Well said. A lot to think about there. Ever felt like you need, a secret decoder ring just to really wrap your head around a complex medical diagnosis?
Oh, definitely. Especially when it's something really nuanced, hard to pin down, and honestly, sometimes a bit overwhelming.
Exactly. Well, you're definitely in the right place today. We're doing a deep dive into two conditions that are, incredibly complex and often misunderstood: endometriosis and adenomyosis.
Yeah, and our mission here is really to cut through some of the noise